Okay, hello. My name is Sarah Nick. I'm from Germany and from the KIF11 Kids e.V. we found in Germany. And today we uh, get the chance to ask Sahar Mansour from the UK a few questions related to the KIF11 syndrome. And I think I will just pass on to you. If it's possible, you can say a few things about the KIF11. What does that stand for? What does that cause?
Hello, I'm Sahar Mansour. I'm a clinical geneticist. I work in London, and my interest really is in lymphedema. So I have developed an interest in KIF11 because some of the children with this condition have lymphedema. But this is a rare genetic condition that can cause lymphedema, but also visual impairment with a variety of different eye problems that we can discuss later, and a degree of intellectual disability that can vary from very mild to very severe. There are a few other complications associated with it, but they are much less frequent.
Okay. Yes, we collected a few questions that commonly come up when you have a child with a genetic disorder. And so, what is the likelihood that future children will also inherit the genetic defect once you have one child with a defect?
Okay, so KIF11 is KIF11 associated disorder is an autosomal dominant condition, which means that you only need one faulty copy of the gene to manifest the features of this condition. So we have two copies of every gene, one from our mother and one from our father. And in some conditions, you have to have two faulty copies, like cystic fibrosis, before you have any symptoms. But in other conditions, you only need one faulty copy. Now, about 60% of children with KIF11 have a parent who also carries the same faulty gene. And if that's the situation, then 50% of the offspring will be affected. So you can see from the diagram, the father is affected. He's got one faulty gene, the X, and one healthy copy. And he randomly passes one of his genes to his children. So if the child inherits the healthy copy, they do not inherit the condition. But if the child inherits the faulty copy, they do have the condition. And so the risk for each pregnancy is 1 in 2 or 50%. And it doesn't matter if it's a boy or a girl, it's always 50%. 40% of children with KIF11 do not have a parent that carry the faulty gene. So this has happened as a new event in the child. And that's because when the egg or the sperm is being formed, it has to replicate, it has to separate, and mistakes can happen in the egg or the sperm as a new event, and therefore it has not been inherited. If your child has a faulty KIF11 gene, but neither parent have it, the risk of this happening again is extremely small, probably in the region of 1%. And the reason it's not 0% is because very, very occasionally, more than one egg or more than one sperm can carry the same fault. But it is a very, very low risk if both parents are clear. So when we make this diagnosis in a child, we always check the parents to see if they carry the faulty gene, because the presentation can be so variable that you can have a parent with very little problems related to this faulty gene.
Okay, so the likelihood is 50% that you pass it on if you have it yourself. What are the options for our kids to have children of their own? Yeah, with such a 50% risk.
Yes. So if your child has a KIF11, a faulty KIF11 gene, so KIF11 related disorder, then they have a 50% chance of passing it on, exactly the same way as this diagram. So if your child is this man here, the dad, he's affected, he can either pass on his faulty gene or his healthy gene, so that their children have a 50-50 risk, regardless of whether they're male or female. They have a few options, and the options are very personal to the couple. So they could decide that, okay, their child has a 50% risk of having this condition, but they can live with that. And they're happy to raise a child with these problems and deal with the problems as they manifest. Or they can say, I'd rather not have a child with KIF11 associated disorder, in which case they can get pregnant naturally, have a genetic test at 12 weeks, which involves taking a small biopsy from the placenta, which in the UK we call a chorionic villus sample. And that will test the baby for the same faulty gene. So within 2 weeks, you would know whether or not the baby had inherited it. Now, you can't fix it once the pregnancy is present. It's not something you can reverse or fix. So the only option at that point would either be to continue with pregnancy or to consider stopping the pregnancy if that's what they wish to do.
Mm-hmm.
There is another option, sorry.
Yes, I think I was going to ask about that. Yes.
Yes. So the last option is to have a test tube baby. So you stimulate the mother to produce lots of eggs, and you retrieve the eggs. You take the sperm from the father, and you have an embryo in each test tube. So you fertilize the egg with the sperm in a test tube. So each test tube has an embryo. And then when the embryo is a few days old, the lab, not me, can literally take a couple of the cells from the embryo and test it for the faulty gene, and then select the embryos that are not affected and implant the unaffected embryos. In that way, you don't need to have a termination of pregnancy, and you can be certain of having an unaffected child. So that might be a good option for a child, for someone with KIF11.
Okay, yeah. I think as a mother of a girl who's already saying that she wants to have babies,
Oh,
it is really good to hear that there are different options, and that it is not excluded for her. Yes, okay.
and that process is getting better and better and better. So the success rate is getting better and better. So it doesn't always work, but it's much better than it was 5-10 years ago. So by the time your little girl's grown up, it'll be much better.
Yes, yes. I like to believe that, yes. Okay, now it's getting a little more technical. Can you explain how the genetic defect causes symptoms, and what symptoms do we know so far?
So we don't know very much about the mechanism of this gene. We know that it's really important for mitosis, which means cell division, so the proliferation of cells. So in that way, I think it's fairly clear why it can cause microcephaly, because the cells are not dividing properly. So the size of the head and the brain doesn't grow appropriately. But this gene, faults in this gene also cause eye problems, which can be short-sightedness, long-sightedness, astigmatism, which means it's slightly wonky eyes, and also an unusual, rare condition of the back of the eye, the retina, which is called chorioretinopathy, so pigmentation of the retina. And so some children with this condition can have impaired vision. We don't really understand how this gene causes the impaired vision. The other most frequent feature is the lymphedema, which happens in about 50% of children with KIF11. It's usually present at birth. It can present later, but it's usually at birth. And we, again, do not understand why this particular gene causes a problem with the lymphatic drainage. but these children can have swelling of their feet and occasionally have more extensive lymphatic problems.
Mm-hmm. As you're an expert on the lymphatic system, we in Germany always talk about that the feet look really bad at birth. Usually, we always say that the toes, they look like little grapes because they're
Yeah.
really round, and but it usually gets better, or we don't really know if it gets better, but the feet look more towards the normal shape of feet once they grow older. Um, does it, can you actually say it gets better, or does it stretch in a way? Can you explain that? Because we always wonder about that.
So the most common presentation of the lymphedema is swelling of the back of the foot. It looks like a balloon at birth, doesn't it? The back of the foot looks swollen like a balloon. And the nails are really small and upturned, and the toes are like little sausages. So that's the most frequent presentation. Both feet are swollen from birth, and it's mainly the feet. The lymphatics rely on the muscles around them to contract. And so as your child starts to mobilize, starts to walk, starts to crawl, quite often the swelling goes down a bit because there is more constriction of the lymphatics, more drainage from the lymphatics. So they can improve on its own when the child starts to mobilize. You can also help the drainage by using well-fitting compression garments or bandaging, and that can bring the swelling down. And we now start treatment in the first year of life. We didn't used to, because the child's feet were growing so quickly that once you measured them, the measurements were out of date because the child had already grown. But we're now getting better at using bandaging initially and then compression garments to reduce the swelling. And what's really interesting is these small upturned nails are because of swelling of the nail bed. So if you can reduce the swelling in the toes, the nails go back down and they can look normal after a few months or years of compression. You can have normal looking nails, which of course are much easier to cut than the small upturned nails. So yeah, some children have ongoing problems with the lymphedema, and some kids get better once they start to walk.
So walking is already one way of a treatment in a way, and
Yeah.
as you said, compression is also a way of a therapy. But is there any therapy for the entire condition? Is there anything we can do more on a more global scale?
So my big interest is in lymphedema, and every single parent asks me that question. Is there some magic treatment for lymphedema? And I really wish I could say yes, but it doesn't exist yet. It's all about maintenance.
I asked for the more global way of treating the entire problem.
Yes. So at the moment, our only forms of treatment are compression of various sorts and skin care to prevent infection. There's no magic cure, sadly, and it's a shame, not just for kids with KIF11 related problems, but for all our patients with lymphedema. There's no magical treatment. It's all about reducing the amount of swelling rather than curing it. So there isn't a magic global treatment for it.
Okay, but we're happy to hear that there are options of at least improving the edema a little. We do bandaging every night, so that during the day my daughter can actually wear regular shoes, and we're really happy about that. And she doesn't have any pain, so we control what we can control in a way. But is there a likelihood that things will worsen over time?
So it depends on you and your child. So things that make it worse are immobility. So if the child is not moving very much, it can make the swelling worse. Being obese, overweight, is a problem for lymphedema. And finally, the skincare is really, really important. In fact, skincare should be number one, because if you don't have good skincare, you can introduce infection into the feet and cause damage to the lymphatics. So recurrent infections such as cellulitis is a real problem. So you have to really be careful not to let the child cut the feet, not to walk on the beach where you might get a cut, to treat insect bites or cuts with antiseptic cream, to moisturize the feet, to treat eczema, and to treat athlete's foot so that there's no cuts in the skin that can introduce infection.
Mm-hmm. Um, in Germany, we have a few kids with edema in the face, or sometimes the eyes are swollen. Have you any patients with edema on other body parts rather than just the feet?
So I don't think so. We've got probably about 10 people with KIF11 related problems. And of course, because it's a lymphedema clinic, they all have lymphedema. But I haven't seen edema of the face or the hands. I am aware from you and from Karina that some of these children can have a problem in absorbing fat from the bowel, which is called intestinal lymphangiectasia. And when you don't absorb fat, you also lose protein. So you have a protein losing enteropathy. So you lose protein in the poo. And if your blood protein level is low, then it can cause swelling elsewhere. So sometimes it's not directly a lymphatic problem in the face or the hands, it's because of the low albumin level, the low protein level. So if you can maintain the albumin level by giving these children low fat, high protein diet, I have seen in other patients that the edema elsewhere improves because the albumin level has come up.
Oh, okay. Okay, I didn't know that. Okay, interesting. Um, Um, do you know of any research studies or any clinical trials that are relevant? Maybe in the UK at the moment, we have a lot of people watching from the UK now, I think. So, is there anything you can keep us updated on?
We're doing a lot of work on KIF11, but it's all lab work at the moment that we're trying to work out because we have a lymphedema interest. We're trying to work out how KIF11, the role of KIF11 in the formation of the lymphatics. So it's all lab based, but once they've progressed with that, I think very much we would be interested in we'll see the patients anyway, but recruiting them to studies, maybe doing more blood tests, perhaps even skin biopsies if they agree, to help us understand how KIF11 causes lymphedema. I had a look about other clinical trials for KIF11 and I couldn't see any related to the eyes or the intellectual disability, but you may know of them. I did search today and yesterday, but I couldn't find any. Do you know of any?
No, I don't think we know anything, at least nothing in Germany that we know of.
Yeah.
So, yeah. Um, But we have been asked quite frequently about new therapies. They are starting to treat different genetic defects now with, yeah, therapies that I don't even understand. I cannot even explain what is going on, but there seems to be a lot going on in the genetic research right now. Have you heard of anything related to maybe disorders similar to KIF11, where they're doing any progress at the moment with new therapies? Is that an option for KIF11 in the future, maybe?
I really, really hope so. I do hope so. There are some drugs that inhibit KIF11, but um, the problem with KIF11 associated disorder is too little of the gene. The gene's not working enough. So you don't want to inhibit it, you want to promote it. So it would be amazing if they could find a drug that could promote the effect of KIF11 rather than inhibit it. And I think there's hope for that. And I think, honestly, I think if they find something like that, it might help with the eye problems and the lymphedema. It's quite rare to find a drug that helps with the intellectual disability because it has to cross the blood-brain barrier, and that's much more difficult for a lot of drugs. So I don't know if that's going to be reasonable.
Okay. Um, yeah, one question that we also get asked, nothing we like to talk about, because it's really hard to say, but is it a life-shortening defect? Can we make any prognosis about how long will our children live?
It's quite a new condition. The gene was only found about 10, 15 years ago, and it's like all these things, it's usually found in children first. But we have quite a few of the parents have it too, and they're fine. They're still alive and functioning well. So in my personal experience, I haven't, touch wood, lost any patients with KIF11, but it's a small group and there's not many adults. That I don't see many adults, but I don't see why it would be life shortening. Very rarely, some of the children develop seizures, and seizures, if you have a severe seizure, that might cause life, might cause the demise, but that's rare. And again, I've not seen that happen in this condition.
Okay, so
Probably not.
there's no reason so far to
Yeah.
believe that it is life-shortening. Okay, that's good to hear from an
Yeah.
expert. Um, do you know of any resources that are available to help family who have genetic disorders?
Any resources, did you say?
Yeah, to support to help families with such
So
genetic.
when I see children with KIF11, I always send them to you, your organization, um, because I think you're doing an amazing job, and um, making people more aware of this condition. In the UK, we have a support group called Unique. Oops. And they produce leaflets about rare genetic disorders, and they also can put you in touch with other families with the same genetic disorder. So they've been around for years. It used to be just chromosomal abnormalities. Now they also help with these rare single gene disorders like KIF11, and they're an amazing group. They also provide information about how to access help for your child, where the specialists are, how to get a education healthcare program, that understanding the genetic testing, what to do when you first hear about the diagnosis. And you can access their leaflets from anywhere in the world, so you don't need to be in the UK. And their leaflets are very clear, beautifully written, and very accurate. So I would highly recommend them as a resource. And if you want to join them, then you can as well.
Okay, well that sounds great. Um, yes. Um, is there anything you want to add? Any questions you were expecting and I didn't ask?
Um, I don't think so. I think we know so little about this condition. I think we're still learning. We're very early on in the understanding of what this condition is and what it does. And for example, I've seen many children with quite a lot of problems, severe problems, and then you see their parent with the same faulty gene with minimal problems. So we don't fully understand why there's so much variability. And hopefully that means there's something we can do to modify the severity in the future. I hope so.
Okay, well then, thanks a lot for sharing your knowledge and your time, helping all our families with your knowledge on KIF11, and I hope we get to speak to you again, maybe next year or in a few years, because things are changing so fast and we learn so much. So yes, thanks a lot.
Thank you very much for asking me.